Okay, let's wrap up chapter 14 and we will ready for the exam. So I have put quite a few YouTube videos in here for the for you to watch. I don't want to take up video time here to do that, so I'm going to send those to you, and you send you this PowerPoint, and you can watch those one quick. Got the book pulled up. So what I want to talk about first, let's get over here too. So the liver and the biliary tract. I know that you guys have already been studying this, but so you know that the liver and the gallbladder are geographically connected as well as functionally connected. So they work together. They're basically adjacent to each other, and they rely on each other. So looking at what happens when things go wrong, it affects both of them and the overall digestive process. So we're going to look at some liver pathology and the surgical conditions that are diagnosed by patient's history, their physical exam, what is found during that physical exam, laboratory result changes, a sonography, a liver scan, a CT scan, and the biopsy. So all of that is taken into consideration to figure out what is going on with the liver and the biliary tract, and what surgical interventions are appropriate and suitable for that particular patient. Oops, let's go back to the book. So there's quite a few of these pathologies and disorders that we're going to talk about. So malignancy. So we have primary malignancy, which means that it originated. So if there's primary liver cancer, that means that's the first place it started. If we have secondary, that means it started somewhere else and metastasized to the liver. So that's the only difference between primary and secondary. Now, the symptoms are pretty much the same. So we're going to see abdominal pain, weight loss, a palpable mass, arterial bruit, friction rub, and ascites. And so ascites is definitely a big one. So we know that that is fluid in the abdominal cavity, and you can see it on physical exam. I apologize. I've been feeling well this week, so I've been sleeping well. So it shows. So some of the treatments, you can see the list of the treatments. Hepatic adenoma. So adenoma always means cancer of a glandular organ. And so here we're talking about the glands within the hepatic system. You can see the symptoms of those: right upper quadrant pain. Oh gosh, sorry. And then a massive intra-abdominal hemorrhage. Nodular hyperplasia. So this could be nodules that are found in the liver that are just hyperplastic cells. So they've just multiplied in numbers. Hemangioma. This is kind of like a blood blister in an organ that collects a lot of the fluid, including blood. Hepatic cyst. So sorry. This is a cyst within the liver, as well as an abscess in the liver or trauma, and that includes a laceration. So this is actually one of some of the videos that I had found for you guys, and I've got the links in the PowerPoint for you. The biliary tract. So we have to do the same diagnostic exams that we did for the liver. So we're talking about the gallbladder and the biliary tract. So a lot of those pathologies are going to affect not only just the liver, but they're also going to affect the biliary tract. And that's going to influence the efficiency of the digestion overall. The procedure, liver resection. So this is the most common way that the tumors in the liver are removed. And so this can be either carcinoma of the liver or the gallbladder, but it definitely is used for cancer of the gallbladder cancer, because that way they're able to take out just that section that's connected to the gallbladder. And also, if there's like uncontrollable bleeding, if there is maceration of that parenchymal tissue after any kind of like abdominal trauma, that can be resolved with a resection, and also a transplant, of course. Here is the entire visual of the liver, gallbladder, the biliary tract. All of this is biliary tract, with the exception of the arteries and veins. And then the next page, of course, is going to be the procedure. So I would recommend having this procedure handy while you're like watching these videos. Here's the video of that. We're not going to watch it right now, but so the liver has 8 separate sections, and about 80 to 90 of that can be resected away, and the liver can continue to function. It can even regenerate to a degree. Now, treatment of the gallbladder disease, there is a sequence that is followed. Very conservative treatment first, including non-invasive treatments, and then if that is not successful, a open cholecystectomy with cholangiogram. And so that way there's going to be imaging done during the procedure, and then the next option would be a laparoscopic cholecystectomy. And gallbladder disease is pretty common in the US, and a lot of people have their gallbladder removed. Now, I've also done another video for the ESWL, which is the extracorporeal shockwave lithotripsy. So this is a very conservative treatment for cholelithiasis, of course, which that is gallbladder kidney stones. And so gallbladder stones, not kidney stones, gallbladder stones. And so the ESWL is a really great and effective treatment that is done, and medications are provided as well, because this procedure can be painful, and sometimes medication is helpful in the dissolving of those stones. Now, cholecystectomy and cholangiogram. So these are done usually together. So this is excising the gallbladder, removing that gallbladder for cholecystitis, acute cholecystitis. It is usually done laparoscopically, and it is very successful 95% of the time. Of course, in the book, you're going to have that procedure. I'll zip over there. There's all of the instruments that are used there. So here is going to be your, no, it's not. I thought that, okay, it's the next one. Yeah, here's the procedure of the cholecystectomy. I think this one is with cholangiogram, yeah. Okay, and you can read through that. Here you've got another visual of the liver. You can see the pre-op tests that are done, equipment that's used to set up for this, supplies that are unique to this procedure. You definitely want to be familiar with what blades are used, these specific catheters that are used as well, and the ties that you're going to have in place. And then read through the procedure. And then here we have a cholecystectomy. So this is, there it goes. So now we've even seen the room set up, how that is set up, as well as how the laparoscope's going to be set up, how many trocars, what sizes, endoscopic instrument, and all that's included with that. Supplies that are unique to this procedure, pre-op, and then the procedure itself. Okay. And there's this procedure. It is a really good video for you guys to watch on these procedures. Surgery of this pancreas and spleen. So the spleen, many times we see the spleen being injured in an MVA, so a car accident. And this happens because it is on the left side under the left rib cage area. And so for drivers, if they're T-boned, that is the point of impact. And so there's many times that spleens are damaged, ruptured, or lacerated due to an MVA. And so trauma is the main reason that splenectomies are done. And if you remember, spleen, the purpose of spleen is filtering the blood. And so it's a very bloody organ. And so anytime that there's a rupture of the spleen, it's 100% a surgical procedure because all of that has to be cleared out. It is pretty much a dirty type of procedure because it is a very bloody procedure. And there's a video there for you to watch. Cancer of the pancreas. Let's look at that. So some of those symptoms are very much across the board for all cancer. One of those is unexpected weight loss. A lot of times they don't have pain, but with pancreatic cancer, they do. So there's a lot of cancers that's one of the keys is there's no pain to it until it's very advanced and like stage 4, and then we'll be seeing some pain. But with pancreatic cancer, the most common symptom is intractable upper abdominal pain. It's constant and dull. And intractable means nothing, no treatments have any effect. So also malabsorption of nutrients. And so we see diarrhea, weight loss, nausea, vomiting, low-grade fever. Respiratory problems could be in there. Absence of normal bowel sounds is a big one. Jaundice. And so this is because that common bile duct is being compressed, as well as diabetes may show up too. So those are some symptoms of pancreatic cancer. And then pancreaectomy. I didn't do a video of that one. You can look on YouTube if you want to see that one, but it's not a super common one. So hernias. So this video is really good because it shows actually what a hernia is about. So it is that protrusion of part of the abdominal tissue, so part of that viscous tissue. There is an opening, a tear in the wall of that peritoneal cavity. And so then some of that internal tissue, which is the viscous, is pushed through that area. It could be an internal hernia could be interparietal or external. Now they can be congenital, so individuals may be born with a hernia. We do see a lot of hernias immediately after birth, and so especially like umbilical hernias, those are usually kind of the more common that are immediately after birth. It could be acquired or a combination of both. So sometimes hernias can happen just because of excess abdominal pressure. So like someone that lifts weights and does so with incorrect body mechanics, that can cause a hernia. There are several different types that are outlined. We're gonna, here's the, I missed this, pancreatic duodenectomy. And so this is where they're excising the head of the pancreas and the distal 1/3 of the stomach and all of the duodenum and about 10 centimeters of the jejunum. So I did not include that. I actually think I did. The Whipple, yeah, I'm sorry, I missed this slide, so sorry. So this is a video of this Whipple procedure, which is this procedure where they're removing this distal third of the stomach, all of the duodenum, 10 centimeters or more of the jejunum, and the gallbladder. You can see the gallbladder's gone as well. So this is where they're removing it, and then this is reconstruction. And here's the procedure. I'm not going to go through that. I appreciate you guys bearing with me. I'm still not anywhere near 100%, but I'm getting through it. Okay, there's the procedure. All right, splenectomy. We talked about that while that is done. Here's all the pre-op stuff, equipment that's used, unique supplies, physician. And you can see here, contact blood bank. Confirm availability of blood because there may be a need for blood. And then it can also be done laparoscopically. So here's the laparoscopic splenectomy. And then moving into the hernias, different types of hernias. Okay, so we've got in the groin area, we could have an inguinal hernia. So that is above that abdominal crural crease, and that can be in a direct or indirect type of hernia. And then the femoral is below that abdominal crural crease, and that's almost always in a female. And then the ventral, so this is anywhere on the abdominal surface typically, and not the groin. So linea alba, so the line down the center of the abdomen is a very common place for these hernias to be. You can have it epigastric, an umbilical, or a hypogastric. Also at the semilunar lines of the abdomen is a fairly common place. And then incisional hernia, so this can occur after a surgical procedure or at a stomal site. So this is just where that tissue is weak and bulges out of that incision or suture. Diaphragmatic, so this is hernias in the diaphragm. We do usually see it at the esophageal hiatus. So, and then you can see there's different types here, you know, as far as like how they're, if they're reducible, like you can manually manipulate them back into the correct space, or if they're irreducible or incarcerated, you can't manipulate it back in, and it can become strangulated. So strangulated is another term, and this is where it has entrapment. So it compromises the vascularity of the circulation in that. Ritger's or Reitger's, this is where it is strangulated, but then it spontaneously reduces. But then what happens is then we can have like a gangrenous portion of the bowel. It a lot of times is overlooked in that hernia repair. A sliding hernia. So this is usually where the abdominal viscera will slip up through the diaphragmatic hernia, the diaphragmatic hiatus, and into the esophagus, and it forms this little hernia sac. And then there's different types, like we said, the inguinal, acquired. In the Hesselbach's triangle, so this is bound by that inguinal ligament. You just want to be familiar with where that at, lateral border of the rectus abdominis, inferior epigastric vessels, and the inguinal ligament. All right, and then of course the hernia repair, different types of those. Bassini or Bassini-Schuldis repair is one that's used. So McVeigh, this is Cooper ligament. And so there is a specific Cooper ligament repair. Let's see if they've got it in the picture of it. Oh, and then the TEP. So this is a total extraperitoneal patch. And this is a lot more common today, where they're doing the inguinal repair laparoscopically. And then at the end, they place a synthetic mesh, and we have a ton of those meshes in the lab for you guys to, there's the mesh. And so that's placed over that herniated tissue. Here's the McVeigh, the Cooper ligament. Let's see if it has imaging of it. No, it does not. Okay, let me see. I don't think this hernia repair that I had put in here was a Cooper ligament. So that would definitely be something that, you know, especially once you get into your clinicals, you want to just watch some YouTube videos on that and get familiar. Here's the laparoscopic inguinal. And then here's a ventral. This is on the front abdominal cavity. So it could be like an umbilical hernia, or the linea alba, I'm sorry. And then here is the umbilical one. And then breast surgery, of course, the majority of those you're going to see on female, males can have breast cancer. So it's not limited just female. The treatment of breast cancer, it is multidisciplinary. So there's a lot of treatments that are being done. You usually see radiation, chemotherapy, and as well as surgical. Of course, there's a great emphasis on finding the cure for this. Breast cancer has been staged. So we have different stages. Let's look at that. If we can go. So stage 1 is where the cancer is 2 centimeters or less in size at the area of the greatest diameter. And we don't see any evidence of regional or distal spread. So there's nothing right at the area of the nodule and nothing around it. Stage 2, the tumor is greater than 2 centimeters, but it's not any larger than 5 centimeters. And we don't have any axillary nodes that are present, and no distal spread. Stage 3A, so there's 2 3s. The tumor will be up to 5 centimeters in A, may or may not be fixed, homolateral, clinically suspicious regional spread, or the tumor can be greater than 5 centimeters. It may or may not be fixed, and it can or cannot have that clinically suspicious homolateral regional spread. So somewhere on that same side. And then no evidence of distal of distance metastasizing, just right at it could or could not have local spread in that breast tissue or surrounding tissue. And then 3B, the tumor can be any size, and there is unequivocal metastasis in the supraclavicular or intraclavicular nodes, so lymph nodes. We could also see edema of the arm without any distant metastasis. Now, stage 4 is tumor of any size, could or could not have regional spread, but we do have metastasis. And then the procedure itself is here, reading through that. And what I did was this one. I did the modified radical mastectomy. So this is where they remove the breast along with the axillary lymph nodes. And this is usually done in stage 1 and 2 when it's done with chemo and radiation, or for anybody in stage 3 or 4. And then here's where there's a sentinel node biopsy, and they use the blue dye to locate that. And then the modified radical procedure is next. And then let's go to the surgery of the thyroid and parathyroid. So the conditions that we have with the thyroid, of course, we have hyperthyroid or thyroid toxicosis. And when you think about hyperthyroid, I want you to always think about everything in the metabolism being hyper. So there's like nervousness, tachycardia, tachypnea, just eyes bulging. There's a lot of, everything is in excess. And so there's medications that they can use to treat this. They also can do a radio iodide ablation of the active thyroid tissue, or they can just remove part of the thyroid or all of it. And then they can also do the surgical resection for cancer of the thyroid. Now, the parathyroid, of course, we know that that is those 4 little glands on the backside of the thyroid that regulate our calcium levels. And so when there's hyperparathyroid, that is a laboratory finding usually. And so we can just surgically resect the affected glands. We never want to remove all of those glands because that is what regulates our calcium. Hypoparathyroid, here we're going to treat that primarily with supplementing calcium, vitamin D, diet is controlled, and antibiotic therapy if there's an infection there. And then the thyroidectomy. This is usually done for that hyperparathyroid or the thyroid cancer. Here is that procedure. And I do have one here's the thyroidectomy. So those parathyroid glands must be spared because if they're removed, we have no calcium control, and tetany is the life-threatening condition there. Okay, all right, I know this is short and I apologize, but I'm struggling just to get this done for you guys. But if you have any questions, let me know, and I'll get this recorded, or I'll get this recording put up right away, and I'll send you the PowerPoint. Thanks a lot.